defect, which means that the platelets aren't working properly. So that's roughly speaking. Now, the other classifications of platelet disorders is, okay, it could be a quantitative or qualitative defect, but is this something acquired or is this something that the patient was born with? So that's the general classification of platelet disorders. And it helps guide you in terms of what questions you need to ask a patient that presents with bleeding symptoms. Just give me 1 minute, please. All right. So خلينا نكمل. So this is just a review or revision of the platelet function. We know that we have primary hemostasis and secondary hemostasis when someone bleeds or has an injury to the endothelium. Primary hemostasis is mainly a function of platelets and von Willebrand factor and subendothelial collagen. And secondary hemostasis, that's responsible for stabilization of the clot and the formation of a thrombin burst and a fibrin stabilization is the function of the coagulation cascade. The most important thing is that we need to know the certain receptors on the platelets that are responsible for the interaction with other very important molecules. For instance, that glycoprotein 6 is responsible for binding to subendothelial collagen on endothelial injury, and that glycoprotein 1b59 is responsible for binding to von Willebrand factor. Thromboxane A2 is very important as well in the platelet activation system. Thrombin, so this tells us that the primary hemostasis is interlinked with secondary hemostasis. So as soon as the platelet is activated on exposure to subendothelial collagen and binding to the subendothelial collagen to glycoprotein 6, there's an activation of the platelets with conformational changes, increase in cyclooxygenase pathways and production of more thromboxane A2, upregulation of the ADP receptors that are very important on the surface of the platelets, upregulation of intracellular calcium, and increased production of thrombin and basically formation of thrombin on the surface of the platelets, so that when the coagulation cascade or secondary hemostasis is activated, it binds to thrombin and a thrombin burst is formed on the surface of the platelets, therefore causing linkage of fibrinogen or activation of fibrinogen to fibrin and then cross-linking of the fibrin molecules. Also, as we know, secondary hemostasis includes both intrinsic and extrinsic factor pathways that are usually cross-linked together and are both activated at the same time. Also, you need to remember that we have, platelet granules. There's alpha granules and there's delta granules that are very important in stabilizing the platelet activation response. So without the alpha and delta granules, the patient might have a good platelet response initially to endothelial injury, but they can't maintain that response. As we go through the lecture, you'll start to know the significance of these information. So, like we said before, when we're talking about platelet disorders, it's either congenital or acquired, and then it's either quantitative or qualitative. Quantitative disorders, acquired quantitative disorders, means anything that might cause thrombocytopenia. It could be an isolated thrombocytopenia like we see in ITP or drug-induced thrombocytopenia, or it can be thrombocytopenia associated with anemia, like we see in microangiopathic hemolytic anemias, or pancytopenia like we see in aplastic anemia. Now, when it comes to congenital qualitative platelet dysfunctions, they're classified according to the platelet size into micro thrombocytopenia, macro thrombocytopenia, or normal size of platelets. Or if sometimes it's not thrombocytopenia, it's a platelet dysfunction only, where the platelet counts are normal, like we see in Glanzmann's thrombocythemia. So you don't need, I know this is probably confusing for you as of yet, but we're going to explain each in details as the lecture goes on. So before we go through the lecture, I want a volunteer to let me know if you have a patient that comes to you with bruising, petechia, and they say, I feel like I have easy bruisability. What are the significant points in history you need to ask the patient about in order to first of all determine if the patient has a possible significant bleeding disorder or bleeding propensity, and then to figure out what the cause of that bleeding propensity is. I think that's the take-home message that you need to get, we need to conclude from this lecture today is how to approach a patient that has a possible bleeding disorder. Do we have any volunteers that would like to give it a go? No one? Well, I'm going to start asking randomly. So, Noor al-Ifeshat, are you there?
Yes, دكتورة.
Fine. So you have a patient that tells you, I notice that I have bruises with no
امم
prior history of trauma, and I easily bruise. شو
امم
questions اللي بدك تسأليه للمريض in the history that will help you determine if this patient فعلا has a possible bleeding propensity or bleeding disorder, or it's just normal bruises that doesn't need further investigations. What do you think?
رح أسأل عن bleeding time، إنه بالعادة لما ينجرح قد إيه بياخد وقت لحتى يلتئم إنه يبطل ينزل دم.
يعني if the patient has prolonged bleeding after minor cuts. Okay, غيره.
آه رح أسأله إذا بيلاحظ مثلا بروزز بأي مكان بجسمه حتى لو ما تعرض لضربة أو أي شيء.
يعني non-trauma, so spontaneous bruising without a history of trauma. طيب.
Yes.
So is it common for us to find bruises on certain parts of our body with no previous history of trauma that we remember?
Yes.
It is. But which part of the body is usually common to have bruises with no prior trauma?
I think maybe lower limb.
Yes, exactly. So what would be alarming for you is to find a bruise, for instance, on the trunk, the back, or the abdomen with no prior history of trauma. Because in order for a patient to have a bruise in these areas, they would have had a significant traumatizing event that they would have remembered, right?
Yes,
شكرا.
exactly.
Thank you. Again, I just want you to send your full names بالاسم الرباعي على الشات عشان الحضور الغياب لأنه أسماءكم يعني some of them first name, some of them حتى مش مبينين بالتفاصيل. Um, sorry. Okay. So I'm gonna ask someone else, unless there's participants. مكرم. مكرم موجود؟ اللي ما بيرد راح احطه غياب باي ذا واي. نادين شبلي موجودة؟
موجود دكتورة.
طيب نادين أعطيني more
آه.
questions. What are you gonna ask?
راح أسأله عن الدراج هيستوري.
Drug history is very important. لا okay, you're right. However, لما تيجوا تاخذوا history للمريض, first of all احنا بدنا نتأكد انه هل هو فعلا عنده bleeding propensity. فالأسئلة اللي بدي أسألها mainly بتركز على انه هذا المريض عنده bleeding propensity ولا لا. بس نتوصل للconclusion انه فعلا عنده bleeding propensity. The second half of my questions would be what are the possible underlying causes. فتركيز أسئلتي ساعتها راح تكون على what are the possible underlying causes. ساعتها بيجي دور الدراج هيستوري. سو خلينا مركزين على شو الأسئلة اللي بدك تسأليها للمريض حتى تعرفي إذا إنه هل bruises means إنه المريض عنده significant bleeding history. زميلتك حكت إذا كانت البروزز spontaneous أو بتطلع بأماكن غريبة like the trunk, the back or the abdomen. الموضوع الثاني prolonged bleeding after minor cuts. Can you remember anything else?
لا صراحة.
Thank you. رنيم.
Oh, yes, doctor.
Go ahead.
Maybe I'll ask the patient if the bruise is deep or superficial. Does it reach the bone or like
Bruises are بشكل عام they're always superficial. إذا إنه في عندك blood collection that's deep seated, that's called a hematoma.
yeah, I'm talking about it actually.
Yeah. Anything else? نور العلوان.
دكتورة ممكن أسأل إذا عنده جنب bleeding
Thank
أثناء
you. So
أو بستاكسز رعاف أو شيء زي هيك.
exactly. شو كمان؟
يعني
ممتازة.
خاطر في بالي هدول التنتين صراحة للأمانة.
Doctor,
Exactly.
can I talk?
Yeah, go ahead.
Menorrhagia, maybe.
Yes, so if it's a female patient, we need to ask about menorrhagia. Do you know what the definition of menorrhagia is, Doctora?
Severe bleeding.
So severe bleeding, you need to have specific criteria حتى تحكي إنه severe. So if you ask 100 females, if you have heavy menstrual bleeding, probably 90 of them are going to say yes. But in actuality, it's a very small number of patients that are going to have actual significant severe bleeding. So you didn't take gynecology yet, so I'll let you know. So if a patient uses large sanitary pads and needs to change them once every 2 hours, or there's passage of clots, or there's signs of hemodynamic instability, so symptoms of hemodynamic instability like lightheadedness, shortness of breath, and palpitations, that indicates that the menstrual cycle is too heavy. So basically, in short, if you have a patient that has a mucocutaneous bleeding symptom, you need to ask about the other mucocutaneous bleeding symptoms. So bruising or petechia is a mucocutaneous bleeding. So we need to ask about the other mucocutaneous parts of the body that might be bleeding, including the nose, epistaxis, the gums, so gum bleeding, hematemesis, melena, hematuria, menorrhagia. Okay? So based on that, there's something called the ISTH bleeding assessment tool, which is short for International Society of Thrombosis and Hemostasis bleeding assessment tool, where there's points on each and every one of these of what I've mentioned. And based on that scoring system, you can conclude if the patient has a bleeding disorder or has a significant mucocutaneous bleeding that needs to be further investigated versus this is normal and doesn't need to be investigated. Also, you need to ask about deep-seated bleeding, like prior history of intracranial hemorrhage, retroperitoneal hematomas, and so on and so forth. Now that we've concluded that the patient might have a significant bleeding disorder, we need to ask about the possible causes, okay? So who would like to give it a go and tell me what questions are important to know the underlying causes of a bleeding disorder?
Doctor, we can ask about family history.
Family history is very important because what does it tell you? ايش
إذا
المعلومة اللي
patient
بتفيدك
has-
فيها family history؟
دكتور ممكن يكون عندهم هيموفيليا أو هاي الشغلات.
So it will tell me if the patient is more likely to have had a congenital bleeding disorder versus an acquired disorder. Thank you so much, Doctor. Anything else?
دكتورة ممكن من drug history أصلا المريض ممكن ياخذ anti platelet drug.
Exactly. Thank you, دكتورة. So بدنا نسأل عن drug history. من ضمن drug history بيهمني antiplatelets, obviously, for obvious reasons, because it works against the platelets. But also, I need to ask about other drugs that might cause drug-induced immune thrombocytopenia, as listed over here. There's a large variety of drugs that can cause that, but the most common are penicillins and cephalosporins, which we take very, very commonly. So it's very important to ask about these. Anything else? It's
Um,
literally in front of you on the slide, by the way. Anything
liver
else?
disease.
if there's renal failure history or liver disease, vitamin
Why?
deficiencies.
Okay, so why is renal failure important? What does it do to the platelets? Anyone? So,
Can
yeah,
I say?
yeah.
Because in chronic kidney disease, the platelet counts are not normal. Maybe it's impaired, so the platelet function is impaired also.
So the counts are okay, but usually uremia in end-stage renal disease interferes with platelet function, so it causes an acquired platelet dysfunction disorder. Also, like you mentioned, in liver failure, patients will have a mild thrombocytopenia, but also liver failure can cause coagulopathy because all coagulation factors are produced in the liver except, does anyone know? Factor
Factor
8,
eight.
yes, and von Willebrand factor. Thank you, Doctora. All right, so just for time's purposes, because we wasted 40 minutes trying to find a link. So first of all, if you have a patient that might have symptoms suggestive of a bleeding disorder, we need to ask about the pattern of bleeding. Is it mucocutaneous or is it deep-seated? We need to ask about the onset. When did the patient start to notice this? Was it since childhood or is it something new? So that it can help us determine if it's congenital or acquired. We need to do a full bleeding assessment tool scoring system to see if the patient does have symptoms that are suggestive of a significant bleeding disorder. And then we need to ask about prior hemostatic challenges. What a hemostatic challenge means is a challenge to the hemostatic system, either primary or secondary hemostasis. The best challenge is if the patient's had any prior invasive procedures or surgical procedures. So if I have a patient that comes with easy bruising and I ask the patient if they've had a prior surgery and they said, well, I've had a cholecystectomy, for instance, 2 years ago. I bled a little bit during the surgery, but I didn't require blood transfusions and I didn't require resuscitation. That tells me by default that at least at the time of the surgery, the patient had a normal hemostatic system that was functioning completely normal. So that in itself will exclude a congenital bleeding disorder for me. Okay, so that's one thing. Whereas if the patient, for instance, says they bled significantly after a very minor procedure that shouldn't have a significant bleeding symptom with it, for instance, bleeding after circumcision, bleeding after tooth extraction that requires suturing, cautery, or blood transfusions, that will tell me that the patient probably has an underlying bleeding disorder. Okay, and then secondly, I need to, after concluding that the patient does have a possible bleeding disorder, I need to ask about the possible underlying causes. A detailed drug history is very important. These are some of the medications, as you can see here, that are known to cause drug-induced thrombocytopenia. Comorbidities are very important. Renal failure causes uremia and it can affect the platelet function. Liver disease can cause thrombocytopenia, mild degree of thrombocytopenia. Myeloproliferative neoplasms can also cause an acquired von Willebrand disease. Does anyone know why? Or acquired von Willebrand syndrome, actually. And it can also cause platelet dysfunction. So we do have a lecture on about MPNs, but so I'll give you a hint. In myeloproliferative neoplasms, we have so the myeloid cells, which are either the granulocytes, the platelets, or the red blood cells, are proliferating unchecked. So if you have a patient that has a platelet count of 1,000, instead of it being around 100,000 to, sorry, 1 million, instead of being 100,000 to 140,000, what's the possible complication that can happen if you have a marked increase in platelet counts? Does anyone know? Who am I going to pick on? يقين الزعبي. اللي ما بيجاوب راح احطه غياب. It means they logged in or they left the meeting. تولين. يوسف خوري.
دكتورة معك.
تفضل. So شو بتتوقع تكون سبب البليتلت dysfunction أو bleeding disorder اللي ممكن تصير في المريض اللي عنده very high platelet counts؟
coagulations، يعني راح يصير في thrombi formation، ممكن disseminated intravascular coagulations مثلا.
DIC لا. Thrombosis is what you would have expected if the platelets were high, but actually we have patients that will come with an acquired von Willebrand syndrome. Can you think of a possible reason for this?
يعني صراحة لا مش عارف.
ما تكونش خاطرت لك يعني in general, بس يعني if you think about it, what's going to happen is, so the platelets have a receptor for von Willebrand factor. If you have too much platelets, then they will bind to von Willebrand factor and cause a consumption of it. So it can cause an acquired von Willebrand syndrome. Also, in myeloproliferative neoplasms, sometimes if there's too much proliferation of a certain cell that goes unchecked, it might be dysfunctional, okay? Also, foods. So all of these foods have a potential to cause some degree of platelet dysfunction, but we wouldn't expect them to be significant enough to cause bleeding. But why these are important is that if you do suspect a platelet dysfunction and you do something called platelet function assays for the patient, you need to make sure that the patient isn't on any of these of these foods because they can give false positive results. Okay? All right, let's continue. So lymphoproliferative disorders, they can cause secondary ITP, immune thrombocytopenia. All right, let's continue. So these are the possible drugs that can cause, so antiplatelets, you know the antiplatelets and their mechanisms of action, وراح تاخدوها بالcardiology, so I'm not going to waste the time on it. I want someone to have a go on this patient that presented with a history of epistaxis. Who wants to give it a try? I'll help you out throughout the way, don't worry. يلا طلاب أنا بحبش يعني to be يعني بس مستمعين and passive بالlecture. It's better for you to participate so you can learn something. طيب باسل التميمي، تفضل. اوكي، هلا الدباس.
نعم دكتورة.
طيب اقرأي لنا الحالة وشوفي شو رأيك فيها.
تمام. A 13 years old boy presented to you with a history of epistaxis requiring cauterization on 3 occasions. Reports bleeding heavily after tooth extraction requiring resuturing. Parents are consequences.
consanguineous يعني قرايب.
تمام. ISTH bleeding assessment tool revealed a score of 8. He reports on no history of arthrosis or muscle hematomas. He reports a history of fetal BPH in a female cousin who was also a product of a consanguineous marriage.
شو رأيك؟ Is this normal؟
لا، لأنه بالتوث اكستراكشن يعني يحتاج إنه يصير له ريسوتشرينج.
بالضبط. شو كمان يعني إبستاكسس ممكن أنا بسهولة، يعني مش أي مريض بيجيني إبستاكسس راح أحكي عنده bleeding disorder، قد تكون المشكلة لوكو، مزبوط. يا ما عندنا people بيصير عندهم إبستاكسس، المشكلة عندهم ENT. لكن شو اللي gives it away وبحكي لك إنه هاي المشكلة مش والله locally related to an ENT problem is that he had bleeding somewhere else which was after a tooth extraction. Alright. برأيك يعني it's more than obvious، بس is this more likely to be something acquired or congenital?
غالبا congenital لأنه
Why؟
في history بالعائلة.
في history بالعيلة وأمه وأبوه consanguineous. What type of inherited disorder is more likely to occur in consanguineous marriages؟ يعني أنت بتعرفي المودز of inheritance، عندك الإكس linked الأوتوسومال recessive والأوتوسومال dominant. إذا كان في consanguineous marriage بتزيد احتمالية inheritance of which type of these disorders؟
X-linked ممكن.
No؟
الأوتوسومال.
بس الإكس linked بس بيعتمد على جينات الأم basically بالميلز، وبالفيميلز بتكون carrier so it doesn't matter إذا قرايب ولا لا. بس اللي more likely autosomal recessive disorders are more likely to meet in consanguineous marriages. Okay? Alright. So طيب okay. برأيك وين المشكلة عنده هذا المريض؟ is it بالplatelets بالprimary hemostasis يعني platelets أو von Willebrand، ولا بالsecondary hemostasis بالcoagulation factors؟
ما بعرف الصراحة، ما عندي فكرة.
You will know لأني حكيتها قبل شوي. طلع pattern of bleeding. وين البليدنج عنده؟
في الميوكوكتينوس.
Mucocutaneous. أيوة exactly. So which type of disorder causes mucocutaneous bleeding؟ مشكلة بالplatelets ولا مشكلة بالcoagulation factors؟
coagulation factors.
لا بالplatelets.
تمام.
But we have two patterns of bleeding. يا إما هي mucocutaneous تحكي لك المشكلة therefore يا بالplatelets يا بالsubendothelial collagen يا إما بالvon Willebrand factor، أو في عندك secondary hemostasis بيؤدي إلى deep seated bleeding إذا فيها مشكلة، وهي coagulation factor disorders. أوكي؟ So إحنا بس من هاي المعلومات رجحنا إنه المريض أول إشي عنده significant bleeding disorder likely related to primary hemostasis، فيا إما بالvon Willebrand factor أو الplatelets، وعلى الأغلب it's congenital. أوكي؟ So خلينا نكمل. بعرفش ليش بطيء هذا.
دكتورة يعطيك العافية.
الله يعافيك.
دكتورة أنا باسل، ناديت علي قبل شوي بس علق عندي للأسف.
ماشي مش مشكلة. anyways if you have any comments بس ودي لي مسج على الشات برجع بطلع عليها بنهاية السيمينار.
خلص أوكي شكرا.
Okay. على review of history it showed no recent intake of antiplatelet medications or herbal remedies اللي سألنا عنها قبل شوي. طيب بالمنطق you should do on it يعني كinvestigations مش مطلوب منكم كسنة رابعة بالتفاصيل، بس it helps يعني لما تصيروا سنة سادسة بتصيروا more oriented. عملنا له CBC. platelets are 190 times 10 to the power 9 يعني 190 ألف per microliter. Is that normal برأيكم؟ يعني reference ranges أو normal ranges of common blood tests لازم تكونوا عارفينها. It's normal. The size of the platelet was normal. The blood film showed normal platelet morphology and granularity on light and electron microscope. هاي خطأ مطبعي. The PT, APTT and fibrinogen were all within normal limits. So إيش المشكلة على الأغلب بهاي الحالة؟ بس من الهيستوري من هاي المعلومات عرفنا إن المريض على الأغلب عنده a platelet dysfunction rather than thrombocytopenia، وعلى الأغلب congenital. Okay? So history is key. الهدف من الهيستوري taking مش عشان تعبوا معلومات التشيك ليست وتنجحوا في امتحان. every معلومة بيحكي لك إياها المريض بيغير الدايجنوسيس عندك وبيرجح diagnosis over another and therefore guides you to a focused investigation scheme. هذا اللينك إذا بتفتحوا عليه بعطيكم ال ISTH bleeding assessment tool. You can have a look at it on your own. By the way, إذا إجاكم مريض عنده a primary or first degree relative that's known to have a platelet dysfunction disorder or von Willebrand disease وإجاكم ب easy bruising or bleeding ما بتستخدموا ال ISTH bleeding assessment tool. هذا لازم ينعمل له immediately investigations to rule out von Willebrand disease. So it's usually only used for the general population that doesn't have a first degree relative with a congenital bleeding disorder. Okay? All right. هذا مش مطلوب منكم. Don't worry about it. لكن if you see this anytime in the future, this is called light transmission aggregometry. It's a platelet function test. أنا راح أحكي لكم شو اللي راح يكون مطلوب منكم بعد شوي منه. But basically we do this test in order to see if the platelets are working normally and if not where the defect is. اللي interested فيكم راح أشرح لكم إياه in general. What we do is basically actually خليها شوي بس نوصل light transmission aggregometry بشرح لكم إياه. المهم المريض كان في عنده no response to any of the agonists except for ristocetin وفي كمان تست بنعمله اسمه PFA 100 بس this is outdated وما كان في closure. لو مش مطلوب منكم انه تعرفوا هاي التفاصيل رح اشرح لكم اياها بعد شوي بس طلع المريض عنده Glanzmann's thrombocythemia. So نيجي عليها شوي شوي. إذا أنتوا شكيتوا ب congenital platelet dysfunction المطلوب تاخدوا a full detailed history including bleeding from mucocutaneous sites. Prior hemostatic challenges are important, including surgical procedures, tooth extractions, prior trauma, and bleeding after trauma. Family history is important, especially history of consanguinity in the parents. Drug history. Also, on physical examination, apart from assessing if the patient has any signs of active internal bleeding, like postural drop in blood pressure, tachycardia, and so on and so forth, it's important to assess if the patient has syndromic features, dysmorphic features, because some of the congenital platelet dysfunctions بتيجي عندها features أخرى زي mucocutaneous albinism, for instance. Oculocutaneous albinism. Congenital abnormalities, albinism, lung fibrosis. Workup, it's important to at least start with a CBC, a mean platelet volume, a blood film, if the blood films to assess the platelet morphology and the size of the platelets and make sure if there is actually it's an isolated platelet dysfunction or if there's anything else going on like having red cell fragments, for instance. So the light microscopy will give you the morphology of the platelets, the granularity of the platelets, and then you have platelet function assays. The platelet function assays includes these 4 assays. Now, what the PFA 100 is basically, I don't know if I've mentioned it before. When I get to it, I'll explain it, don't worry. Okay, so in general, congenital platelet disorders are classified into macrothrombocytopenias, which means that the platelet is large and the number of the platelets are low. The most important of these is a condition called Bernard-Soulier. So you have large platelets, low in number, not functioning normally. And then others include MYH9 abnormalities and gray platelet syndrome. There's a vast majority of abnormalities, congenital abnormalities that manifest in thrombocytopenia as well as other abnormalities within the body, syndromic features. Normal platelet size, you need to think about Glanzmann's thrombocythemia, Chidiac-Higashi, and Hermansky-Pudlak. And microthrombocytopenias, you need to think about Wiskott-Aldrich syndrome. So you do need to know in general, so it's a common MCQ question, all of the following can cause macrothrombocytopenia except. So you do actually need to know it. As we go through the slides, I'll give you a brief about each and every one of these. So coming to the platelet function assays. A PFA 100 basically depends on putting the patient's whole blood through a cuvette or a tube يعني أنبوب صغير. جوا الأنبوب بيكون في a platelet activator, either ADP or collagen or epinephrine. And then we pass the patient's blood through that tube and we check for the blood going through the other end of the tube. The moment the blood ceases to pass from the other end of the tube, it means there's closure. Closure means that a clot was formed. And we measure the time it takes for that clot to form. Now, if the patient has a very significant platelet dysfunction disorder, it doesn't close, so we call it non-closure. And that's what a PFA 100 means. Okay? I hope that's clear. If you didn't understand it, please raise your hand so I can repeat it. So it's a screening mechanism, a method to look for possible underlying platelet dysfunction. All right. So basically مش حاط أنا scheme. بناخد أنبوب صغير. الأنبوب الصغير فيه mesh. In addition to the mesh في عنا an activator للplatelets. احنا بنعرف إنه الplatelets في على السيرفيس تاعتها receptors. من ضمن الريسبتورز في receptor لل ADP وللثرومبوكسين A2 وللابنفرين و other يعني agonists that stimulate the platelets. فإحنا بنحط الهول بلد تاع المريض بنفوته بسرنجة على الطرف الأول من التيوب وبنشوف كيف البلد بيطلع من الطرف الثاني of the tube. Okay? The moment بيبطل يطلع البلد من الطرف الثاني of the tube it means إنه صار في clot. الوقت المطلوب حتى يصير هذا الكلوت ويبطل يطلع البلد من other end of the tube معناها إنه صار في clot therefore البليتلتس اشتغلت. If there's a prolongation of the time until the clot is formed معناها ممكن المريض يكون عنده platelet dysfunction. Sometimes it's so severe to the extent that there's non-closure meaning إنه ما بيوقف bleeding من the other side of the tube. Now المشكلة في هذا التست إنه it's not sensitive and it's not specific. يعني it depends on multiple factors because they test it on whole blood not just on platelets, which means إنه multiple factors can take a role in causing the clot or preventing the clot from forming, including, for instance, if the patient has a high hematocrit or a high white blood cell count, the clot can form even though the patient has abnormal platelet function. So nowadays we don't use PFA 100 anymore, but you might see it in exams in the future. So it's worth knowing it. The more appropriate way of assessing platelet dysfunction is something called a light transmission aggregometry. Now, I'm not going to ask you about the details of how this test is done, but for those of you that are interested so you can understand the results and how to interpret it, what we do is we take the patient's platelets, so we take the patient's full EDTA sample, we separate the platelets from the rest of the blood cells and the serum. So we take something called a platelet-rich plasma sample from the patient. Now we add to that platelet-rich plasma sample. So if you have a platelet-rich plasma, it's usually not see-through from the tube because it's very turbid. There's a lot of platelets in it. We add to those platelets an agonist. What an agonist is basically something that stimulates platelet aggregation. If platelet aggregation happens, the platelets will all clump up into one single clump. So what's left is the plasma that doesn't have any platelets in it. So it will become see-through. In that case, we generate a light source, and at the back of the tube, there's a photocell. If light is transmitted through the tube, it will form a waveform on the light cell, and you can actually see it. So if you do have a waveform, it means that the platelets were activated, therefore responded normally to the agonist. And that helps us determine if the patient's platelets are working normally to each specific agonist, okay? So, sorry, I should have had a scheme so I can explain it to you. So this is the curve that's generated from the photocell after the platelets are aggregate. I'm not going to give you these diagrams in the exam. All I want you to know is basically these two common abnormalities, which is Glanzmann's thrombocythemia and Bernard-Soulier. In Glanzmann's thrombocythemia, the patient's platelets do not react to any of these agonists, ADP, collagen, epinephrine, arachidonic acid, and low-dose ristocetin. They only react mildly to high-dose ristocetin. In Bernard-Soulier, on the other hand, they react to everything but ristocetin, so it's probably pretty much the negative image for each. You just need to know these two. So the question in the exam would be in the form of, you have a patient that presents with bleeding disorders or mucocutaneous bleeding. We did a light transmission aggregometry that showed no response to any of the agonists but high-dose ristocetin. What does he have? Glanzmann's thrombocythemia. So I'm not going to bring these tables in the exam, just know that Glanzmann's does not respond to any of the agonists but high-dose ristocetin. Bernard-Soulier responds to all of the agonists but high and low-dose ristocetin. That's it, okay? All right, coming to each and every one of these platelet disorders, we have Glanzmann's thrombocythemia. It's autosomal recessive. Therefore, it's one of the disorders that is more likely to occur in consanguineous marriages. The defect is in glycoprotein 2b3a. So what's the function of glycoprotein 2b3A? It binds to von Willebrand factor. So if it's defective, and to fibrinogen, obviously. So if it's defective, the first phase of platelet activation or platelet binding and activation will not happen. So this will manifest with severe, significant mucocutaneous bleeding throughout life that might be spontaneous or after minor trauma. You don't need to know this. It's just for those of you that are interested. There's another way to diagnose Glanzmann's thrombasthenia. So glycoprotein 2b, 3a are receptors on the surface of the platelets. So we check for these receptors via something called flow cytometry. 2b has another name called CD41, and 3a is CD61. So on a test called flow cytometry, we check for the presence of these receptors. If they're not available, it means that the patient has Glanzmann's thrombasthenia. So that's one of the forms that an exam question can come, that we have a patient that comes with mucocutaneous bleeding. The patient had failure of response to any of the agonists, but high-dose risdiplam on a light transmission aggregometry, and the patient had a defective or absence of CD41 and 61 on flow cytometry. Okay, what does the patient have? The second is Bernard-Soulier. It's also an autosomal recessive disorder. The abnormality is in glycoprotein 1b95 complex. That's also important in interacting with von Willebrand factor. So the clinical presentation is similar for both, but Bernard-Soulier, the patient has a large platelet and thrombocytopenia along with it. So this is how a platelet looks in Bernard-Soulier. This is a red blood cell, and this is a platelet. Platelets should be very small. It's like extremely small, like small dots within the blood film. However, these are almost the size of the red blood cell next to it, so they are large, but the granulation is normal, as you can see, the purple hazy color here. Okay? Also, we have something called gray platelet syndrome. It's a very rare disorder. There's less than 100 cases worldwide.
Recording in progress.
Oh, you just started recording? Okay, fine. So there's less than 100 cases worldwide of gray platelet syndrome. We actually have a case of a gray platelet syndrome mimetic in Al-Bashir Hospital we've recently diagnosed as well. So compare the color of this platelet to the one I showed you here. So this is violet in color, whereas this is very gray. They're both very large because they're the same size of the red blood cell. Okay? So in gray platelet syndrome, we have an absence of the alpha granules. Going back to the first slide so that you can know the significance of knowing the normal physiology. So the alpha granules have P-selectin, platelet factor 4, platelet-derived growth factor, von Willebrand factor, fibrinogen, factor 5, and factor 13 within them. So not having alpha granules will manifest with obvious platelet dysfunction and bleeding disorders. Also, these patients are more prone to having myelofibrosis, so fibrosis of the bone marrow. All right. Then you have storage pool disorders or disorders of the dense or delta granules. This includes something called Hermansky-Pudlak syndrome. It's usually seen in patients of Puerto Rican descent. Shiriak-Higashi syndrome, I'll tell you about it in a moment, and idiopathic dense deficiency. So, if the patient has a dense granule disorder, the patient will have on the light transmission aggregometry, they'll have a first wave that's normal, but absence of the second wave on aggregation, which means basically, so first there's going to be a first peak, a good first wave, but then it will go down. That means that, so what will maintain the second wave should be the release of the content of the delta granules. If they're absent, the patient will have a normal response initially, but they won't have enough dense granules to maintain the response, so it will go back down. So, Hermansky-Pudlak. It's an autosomal recessive disorder. It's a dense delta granule deficiency or abnormality. The patients present with oculocutaneous albinism, pulmonary fibrosis, and granulomatous colitis. The death is usually from advanced pulmonary fibrosis. Shiriak-Higashi syndrome has a constellation of abnormalities, including oculocutaneous albinism, photosensitivity. Many of them progress to lymphoproliferative disorders and high-graded lymphomas, and this is the leading cause of death with them. What gives it away is that apart from having abnormal platelets, so this is a platelet here, their neutrophils have dense granulations within them or inclusion bodies. Okay? MYH9 abnormalities are also a dense granule deficiency disorder. They usually have abnormalities within the mucous membranes. So sensory neural hearing losses, sorry, not mucous membranes, epithelial membranes. So within the inner ear, sensory neural hearing losses, presenile cataracts, glomerulonephritis, abnormal liver function test. And look at the platelets here, they're huge. And there's, if you can see this gray inclusion within the neutrophil, this is called a Dole body. And this helps in diagnosing MYH9 abnormalities. Wiskott-Aldrich syndrome is one of the microthrombocytopenias. Look how small the platelet is here. The patient has severe eczema. They have immunodeficiencies, and usually the main issue within Wiskott-Aldrich is the immunodeficiencies. So they come with recurrent infections, and it's X-linked. What's the significance of an X-linked disorder? Let me ask someone. Any volunteers? Okay, so I'm going to pick on someone in that case. حلا الدباس حلا أنا سألتك actually don't worry about it. تولين يونس أنا ناديت على تولين قبل هالمرة وما ردت so
دكتور موجودة بس أنا سمعتها يقين عشان كان قبلها تنادى على يقين.
That's fine. Okay, ماشي تولين. So لما أحكي لك إنه المريض عنده X-linked disorder, what does that tell you in terms of inheritance?
It affects all men.
It only affects men.
No, it affects
والinheritance
women
بتكون من
too.
الأم ولا الأب؟ يعني
من
الإلهام اللي بيكون مصاب فيها جاي بالinheritance من الأم ولا من الأب؟
من الأب.
من الأم، لأنه الميل باخذ الإكس كروموزوم من مين؟ الميل بيشنت اللي اكس واي باخذ الإكس كروموزوم من مين؟
من أم.
من الأم، exactly، لأن الواي ماخذه من الأب. Which basically means إذا الأم is a carrier, she will transmit the disease to her male children at a 50-50% chance لأنها عندها 2X chromosomes. Okay? البنات of that affected, the carrier mother will have a 50-50% chance of being carriers. طب بدي أسأل سؤال أصعب شوي. Do you know a condition or a circumstance where a female patient will not be a carrier but will actually have a full-blown disease manifestation of an X-linked disorder?
I'm not sure.
Thank you.
No,
Anyone?
it's not the Turner syndrome.
مين اللي بيحكي؟
Darina.
Thank you, Darina. Go ahead.
No, I'm saying if she has Turner.
Yeah, because she only has one X chromosome. That's one. Anything else?
صراحة that's what came to my mind.
Okay, think about something else. Anyone?
تيرنر، ممكن تيرنر.
حكت Turner.
ممكن كمان لما الهوموزايجوسيتي أو الكومباوند هيتيروزايجوسيتي.
No, because you have 2X chromosomes.
طيب
If you
السكيود كمان ممكن سكيود X
اسمها skewed.
inactivation.
Exactly. شو بنسميها هاي اللي هي extreme lionization of the X chromosome. فإحنا يعني الفيميلز عندهم 2X chromosomes في some degree of lionization. يعني واحدة من الX chromosomes بتكون more dominant من الثانية. But in some circumstances there's extreme lionization بحيث إنه واحدة فيهم very dominant والثانية لا. إذا حصل إنه ال X-linked disorder is on the X chromosome that's dominant بتصير عندها severe manifestation. الاحتمال الثالث إنه المريضة isn't a female أصلاً. فعندها androgen insensitivity syndrome, and actually on a chromosomal level she's an XY patient. Okay? Thank you. ليش مش راضية تمشي هاي؟ alright. So كمانجمنت انتوا كسنة رابعة ما حدا رح يطلب منكم مانجمنت، بسنة سادسة you will need to know it. بس بشكل عام إذا واحد عنده platelet dysfunction disorder, it's important to refer the patient to a 24-axis hemophilia or bleeding disorder center. احنا ما عندنا هذا الاشي بالأردن، بس at least إنه المريض يكون متبع مع tertiary hospital with expert hematologists. Lifestyle changes including avoiding contact sports, avoiding anything that might affect platelet function further like NSAIDs and aspirin. It's important that these patients receive hepatitis B vaccination because they have a bleeding disorder, so they're more prone to having blood products in the future. So it's to prevent any blood-borne viral infections. iron replacement, and sometimes, so advances in medicine now have made it possible that patients that have inherited disorders can be cured with gene therapy. And if there are abnormalities within the bone marrow, stem cell transplantation. However, gene therapy costs $2.6 million as of yet. Management of acute bleeding episodes. So we have something called tranexamic acid, which is an antifibrinolytic treatment. So it prevents the fibrin from becoming lysed, therefore stabilizing the fibrin clot. Desmopressin for platelet storage pool disorders. Desmopressin enables the dense granules to release their contents. Platelet transfusions, because if you give a patient that has dysfunctional platelets, a donor platelet that works normally, it can help in stopping the bleeding, inactive bleeding. And Novo-7 or recombinant factor 7, which is licensed for Glasman's thrombasthenia. Okay, you don't need to know this question, it's too complicated for you, don't worry about it. Okay, now coming to acquired platelet problems, it could either be quantitative or qualitative. Now, when it comes to, I'm not going to talk about the qualitative disorders, it's too complicated for you, but quantitative disorders, if there's isolated thrombocytopenia, the first thing you need to think about is immune thrombocytopenia purpura, and it's a diagnosis of exclusion, which basically means you can't say this patient has ITP unless you've ruled out everything else that can cause isolated thrombocytopenia. Have drug-induced thrombocytopenia, and if a patient presents with low platelets after a blood transfusion or a platelet transfusion, you need to think about the possibility of a post-transfusional purpura syndrome, which is an emergency. Okay, so ITP is a diagnosis of exclusion. It's immune-mediated. So there's autoantibodies that bind to the patient's platelets, causing opsonization and clearance within the spleen. There's secondary causes of ITP, including a long list of disorders, which we need to check for when we're suspecting ITP, including autoimmune workup, antiphospholipid screen, H. pylori infection, hepatitis B and C, and an underlying lymphoproliferative disorder. Some patients develop ITP post-vaccination. We've had a very high surge of ITP patients after the AstraZeneca vaccine in 2021. Also, after the COVID infection itself. Other vaccines that are known to induce ITP are the MMR vaccine and the varicella-zoster vaccine. Okay, so what do you do for any patient that might present with, mucocutaneous bleeding, like we said? CBC. The point of the CBC is to see if it's an isolated thrombocytopenia versus anemia and thrombocytopenia or pancytopenia. A reticulocyte count and hemolysis screen is important if the patient also has anemia, because this could indicate a microangiopathic hemolytic anemia, or it can also indicate that the patient has autoimmune hemolytic anemia along with thrombocytopenia, which is called Evans syndrome. A blood film is very important to assess platelet morphology, confirm that there's actual thrombocytopenia and it's not a lab error, and make sure that the red blood cells are normal and there's no fragments. And then, like we said, autoimmune workup, HIV, hepatitis B, H. pylori infection, and immunoglobulins. Why immunoglobulins are important is because one of the secondary causes of ITP is an inherited immunodeficiency called common variable immunodeficiency. So we need to do immunoglobulin levels to rule that out. Thyroid function tests are important simply because autoimmune conditions come in constellation. So if a patient has one autoimmune condition, they're more prone to other autoimmune conditions. That's why you can see patients coming with vitiligo, hypothyroidism, type 1 diabetes, celiac disease, and ITP altogether, which is called autoimmune multi-endocrinopathy, type 1 and type 2. Okay, so the most important thing for you guys to know is that it's a diagnosis of exclusion. You do not say the patient has ITP unless you rule out other conditions. There's not a specific test you can do to confirm ITP. In terms of management, I'm not going to ask you about it, but basically we say there's acute, persistent, or chronic ITP. It happens in children and adults. Adults are more likely to have a chronic course, whereas children usually have an acute course that resolves spontaneously after a viral infection. Management, I'm not going to ask you about it. When you're a 6th grade student, you're probably going to need to know about these details in management, so keep that in mind. But for now, I'm not going to ask you about management. So this is just for reading purposes. I'm not going to ask you about it, okay? Next, we have something called microangiopathic hemolytic anemia. What it means is that the coagulation system is working unchecked, therefore causing microthrombi within the small blood vessels. And as a result, the blood vessel lumen narrows down, and as the red blood cells flow within the lumen, they are destructed, and there's shear stress, and they're torn apart, forming fragments or schistocytes. The patient develops thrombocytopenia due to consumption of the platelets within the microvessels. So we have TTP, thrombotic thrombocytopenic purpura, which is an emergency. You need to suspect it if the patient presents with new onset neurological dysfunction. Sometimes they present with myocardial infarction or other manifestations of tissue ischemia, with thrombocytopenia, anemia, low-graded fever, and acute kidney injury. On suspicion of TTP, it's very prudent that within the first 9 hours of presentation, the patient has plasmapheresis, which is life-saving. It's confirmed by assessing ADAM-TS13 levels and antigen and antibodies against ADAM-TS13. Now, give me a moment, just because this is very important and life-saving, I need to ask you guys about it. Does anyone know what ADAM-TS13 is and why it exists in our body? شذا يعقوب. شذا الدبيبة. اللي ما بيجاوب راح احطه غياب باي ذا واي. تيماء الفقيه. آية عربيات.
دكتورة أنا مو من الناس اللي عم تنادي عليهم، بس ممكن تعيدي السؤال بليز؟
give me a moment. ايش هو الآدم تيس 13 دكتورة؟
دكتورة أجاوب؟
Yes.
ممكن إنه بيكسر الفون فيليبرين فاكتور لأشياء أصغر؟
Yes. So Adam TS13 موجود فينا كلنا الحمد لله. الفانكشن of it is that it destructs von Willebrand factor multimers. فالفون Willebrand factor أول ما يصير له production it's formed in large multimers. Adam TS13 breaks it down to smaller molecules. If it persists in the circulation in multimers, it causes an activation, spontaneous activation of platelets and clot formation. In TTP, the patient has autoantibodies. شكرا دكتورة. In TTP, the patient has autoantibodies directed against Adam TS13. Therefore, it doesn't work properly, and it causes the constellation of these symptoms. مجرد ما شكيتوا فيه, you have to undergo plasmapheresis of the patient, or else the patient will die. And it has a very high mortality rate. هاني عربيات، إيش في عندك سؤال؟
دكتورة قبل شوي سمعتك حكيتي آية عربيات، بس ما بتكوني ناديتي علي وأنا مش سامع.
لا هو في آية I think ولا أنا مخربط.
100%.
في آية not you. Thank you.
تمام.
Alright. DIC برضو is a microangiopathic hemolysis, بس in addition to يعني the anemia thrombocytopenia and microangiopathic hemolysis, the patient has a coagulopathy. So فعنده prolongation of PT and APTT with hypofibrinogenemia. So usually you see it secondary to severe infections and sepsis, and the management of it is to treat the
يعطيك العافية
underlying
دكتورة.
شباب وصبايا، إذا حدا فيكم ناديت عليه وما رد بس ابعثوا لي مسج إنه أنا هيني موجودة بس تأخرت، بس ما don't speak unless you raise your hand. شكرا شباب. thank you. خلص you're here. I got it. السؤال الثاني إلك معناها الجاي. HUS برضه hemolytic uremic syndrome بنشوفه after. طب شو هذا السؤال هذا إلك معناها. HUS hemolytic uremic syndrome إيش البرودروم اللي usually بيجي فيه المريض بيكون جاي عنده
ممكن تعيد السؤال ما كنت سامعة.
طب أنا هيني هلا بحكي لك السؤال، صبرك شوي شذا. في برودروم بتصير في المريض an infectious prodrome prior to hemolytic uremic syndrome. إيش هو بتعرفي؟ أحمد تفضل.
دكتورة الشيجيلا.
مش الشيجيلا.
دكتورة
You close.
شيجا توكسين.
Yes, Shiga toxin producing E. coli اللي هي حدا بيعرف شو اسم السترين؟ كثير بتيجي في الامتحانات.
0157
O157H7. يعني بيجي ببرودروم of diarrhea, a diarrheal illness. بعديها بيجي عنده jaundice, yellow urine, pallor, fatigue, whatever. بنعمل له CBC بنلاقيه anemic thrombocytopenic fragments على red blood cells. And management is supportive usually. Okay? Alright, نكمل. بس في شوية بطء هون. Alright, so حكيت لكم عنها خلاص, you know it. So what are these? Anyone? What are these?
fragment للبلود cells.
Fragments. And this is a platelet, okay? This is how a normal platelet should look. Alright. خلاص. I told you about these. Management مش كثير مطلوب منكم. And that's it. يعني احنا so far خلصنا the first محاضرة. والله not bad يعني. It took less than, it took about half an hour. خليني بس I'm just going to take a screenshot of the names اللي حضروا المحاضرة الأولى عشان يحضروا الغياب. I'm going to stop sharing my screen. بتحبوا تاخدوا 5 minutes break ونرجع؟ خليكوا logged in عشان ما نضيعش وقت وإحنا logging back in and out. Do you want 5 minutes break?
Recording stopped.